if the viral load is zero when we use the common tests, the transmission is also zero. And that is the only absolute truth that I know in medicine. If the viral load is zero, is below detection limit, you are not going to transmit.
Welcome to Science with a Twist, a podcast for curious people who enjoy exploring how science impacts our daily lives. From technology that helps the fight against COVID-19 to solutions that help clean the water we drink, it's all thanks to science. In each episode, members of Thermo Fisher's scientific team talk to experts who are on the cutting edge of redefining how we exist. Let's get started.
Hello, everyone, and welcome back to Science with a Twist, brought to you by Thermo Fisher Scientific, the world's leader in serving science. My name is Dr. Obiageli Okafor, and I'm the Senior Manager of Medical and Scientific Affairs for the Global Health Business and Thermo Fisher Scientific. Today's discussion is really close to my heart because I've had first-hand experience providing medical care to people living or affected by the disease we'll be discussing today. So I'm extremely humbled to host today's episode as we dive deeper into an important and timely issue, which is the need to achieve global health equity in the treatment and management of HIV, particularly in low and middle income countries. One way that we at Thermo Fisher are helping countries reach this goal is through supporting access to HIV drug resistance testing. And our focus today will be on Brazil, a developing nation that has taken a progressive and highly effective approach to addressing HIV over the last 2 decades. Brazil provided access to CD4 viral load testing and new treatments, including making antiretroviral drugs available for free to people living with HIV, beginning as far back as 1996. Brazil is now reaping the benefits with lower than expected HIV cases. For today's episode, we're pleased to welcome Dr. Ricardo Diaz, an infectious disease expert and physician from Brazil, who has conducted extensive translational research in HIV and AIDS, with focus on drug resistance during his 24-year career. He has published more than 200 articles in peer-reviewed scientific journals with nearly 6,000 citations of his work. Additionally, Dr. Diaz serves as a consultant to the Brazilian Ministry of Health, the Laboratory on HIV viral hepatitis, and sexually transmitted disease. He's also currently a professor in the infectious disease department of Paulista School of Medicine at the Federal University of Sao Paulo. In today's conversation with Dr. Diaz, we will discuss what other low and middle income countries can learn from Brazil's approach, and also explore advancements made in addressing HIV as a global public health threat.
Okay, thank you, Obi. Thank you for having me. It's a great pleasure.
But before we jump in, allow me to just give you a brief overview of HIV and HIV drug resistance. So, according to the UNAIDS, the HIV/AIDS pandemic remains one of the deadliest global pandemics in the world, with an estimated 40.4 million people having died of AIDS-related illnesses since 1981. However, the number of new infections each year has significantly reduced since it peaked in 1995. Now, this decrease in number of new infections has been attributed to the emergence and spread of antiretroviral therapy, or commonly called ARTs. ARTs, how they work is that they lead to virological suppression, which means that these drugs significantly reduce the amount of HIV in the body, or what we will typically refer to as viral load. Now, reduced to undetectable viral load means that the risk of transmitting the disease significantly is decreased. And today, antiretroviral drugs or antiretroviral therapy has made HIV a manageable disease. Now, two main reasons why antiretroviral therapy might not be effective are non-adherence to taking the drug and drug resistance. In such cases, this virus will remain non-suppressed. Now, when we have non-adherence, we just, fix it with adherence counseling. But to manage HIV drug resistance, testing plays a crucial role. Rising HIV drug resistance is a growing concern that threatens the effectiveness of antiretroviral drugs. In fact, according to WHO, the rate of HIV drug resistance is steadily increasing. Up to 10% of adults starting HIV treatment for the first time already have resistance to a class of antiretroviral drugs called NNRTIs or non-nucleoside reverse transcriptase. Even for the newer classes, we see countries have already started reporting resistance to them. Newer classes like integrase inhibitor drugs, we're hearing about resistance to those. And so monitoring and management of HIV drug resistance helps ensure that antiretroviral drugs retain their efficacy. Now, while progress has been made in the global fight against HIV, there remains a need to make HIV drug resistance testing common and accessible to more parts of the world, particularly in low and middle income countries. Late last year, Thermo Fisher, working in collaboration with the US Center for Disease Control and Prevention, launched a test designed for HIV drug resistance monitoring. Now, I'd like to welcome Dr. Ricardo Diaz again so we can kick off today's conversation. Dr. Diaz, thank you again for joining us. So, the first question that we have for you, Dr. Diaz, is if you could kindly explain to us what HIV drug resistance is and how resistance develops and why it's on the rise right now.
Yeah, this is very interesting. Every time that you have an infectious disease pathogen and you have a antimicrobial drug, one of the outcomes is resistance. So that's why we learn for HIV and some other disease that we need to combine drugs just to prevent the emergence, the selection of drug resistance. And so, therefore, resistance is going to emerge when we are in monotherapy. And this happens while patients will not be adherent or fully adherent. Maybe they don't take all the pills. Maybe they interrupt treatment, and the drugs will have distinct half-lives. And at some point, there will be a monotherapy. And this is something that really threats the efficacy of our treatment. And this is something that we need to prevent.
Thank you so much, Dr. Diaz. But if we look at HIV drug resistance testing, can you speak to some of the factors that have limited access to drug resistance testing, whether in Latin America or in other countries you've worked?
Yes, this is very interesting. Let me tell the Brazilian history for you to know about this. So we had a very strong step towards HIV. In this thing, we start to have drugs the first time free of charge in the public system. So we had the first drug that was AZT back in 1991. But only 1996, we start to have the combination of drugs, which is the standard of care now. Then in late 96, early 97, we have the viral load. And then we saw that our treatment was not working the way that we want to. And by 2001, we start to do the genotype testing to see resistance. And again, another surprise. Many patients will have virus with resistance. And so that was a new test at that time. And at that time, we saw that we need to expand that tool to just mitigate the transmission of drug resistance. And of course, those are expensive tests for developing countries. And at some point, we don't have the access that we need for all patients that are being treated. And it's very clear now that the drugs are not the only tool that we need. We need the drugs, we need monitoring tests, and we need resistance tests that are more than monitoring tests because they are going to interfere and dictate the new treatments. It's like a precision medicine in HIV care because you are going for every patient to have a distinct treatment according to the profile of the virus that were selected by the treatment and may have some resistance.
Wow. Yeah, thank you. Thank you so much, Dr. Diaz. I think one of the things that we should discuss is the current scale of HIV drug resistance in Brazil, as well as globally.
As you mentioned, we have in Brazil a centralized lab that performs the genotype, and theoretically, it's available to all patients that need this. And for you to have an idea, that lab performs something like 1,500 tests a month. And right now, we would need much more. So we have 650,000 patients on treatment, and 90% of those patients have the viral load below detection limits, which means that 10% of patients right now would need a resistance test, ideally. Would be 60,000 patients. So we do much less than we should. Then, when you look the profile of those patients that are going to do the resistance test because they have virologic failure, we have extensive resistance. We have at least 30% of those patients with resistance to at least 3 classes of drugs, which is much. But I recognize that there is a inclusion bias, because if you are not doing as many tests that we want, we are perhaps doing the test for those patients that have more resistance. But it's interesting to know that there are two kinds of resistance. There is that resistance that the virus with resistance will emerge upon treatment. And this is the kind of test that we do in Brazil, usually in the network for drug resistance that we have. But there is also the transmit drug resistance. When you mention that 10% of patients that start treatment will have resistant virus, we are talking about transmit drug resistance. And in order to sort out by transmit drug resistance, we need to perform the genotype test before treatment, just to optimize treatment before the failure with initial treatment.
Yeah, Dr. Diaz, thank you so much. I think it's something that has stuck with what you said is transmitted drug resistance is evidence that we failed in HIV prevention. And I think that's a message that we need to carry to the world, because right now the focus is on preventing transmission of new infections as well as preventing transmission of HIV drug resistant strain in new infections. And so, yeah, it's very important what you just said, that transmitted drug resistance is truly evidence that we have failed, and that should be put into consideration as countries come up with guidelines and for treatment and prevention of HIV. So I guess just digging back into what you just said, I just want you to help us understand the current state of physician education around HIV drug resistance. Is it something that everybody knows about, but we just don't have resources, or is it something that education also plays an important role in?
Yeah, you raise a very important issue right now, because one of the questions is why physicians are not ordering for resistance testing as they should. What are the barriers for that? Well, one of the barriers is that it is a special test, and sometimes the interpretation of this test is not very easy. So the common physicians that treat HIV, for instance, in Brazil, are not specialists, because you have something like 50,000 patients every year, new patients every year in the public system. So we don't have many infectious disease physicians to take care of all those patients. And therefore, we have general physicians that need to know everything about everything, and sometimes they do not know many about resistance. And it looks like if they order some resistance tests, and I saw that, and they receive a report that they cannot interpret well, this is going to be at least embarrassing for him in front of the patient. And so this is one of the barriers. In Brazil, in our system, we have something what is a specialist, like a physician that is a virology educated physician, which we call reference physician in genotype. So that physician is going to interpret the test and is going to make a report related to that patient's characteristics and the results of the resistance test, which, as I said to you, sometimes is not very easy to interpret, and to send to the common physician that's going to have something easier to guide him to the next treatment level. That's why, because first studies back in the beginning of the genotype testing showed that having the test, the genotype test, without the proper counseling is the same as don't having the test. We thought about that in Brazil, and we trained those specialists, those reference physicians, to interpret the test. And so we have a test that sometimes can be expensive, although cost effective at many times. And we have also the barrier of interpretation of this test for some physicians, and that's something that we need to overcome in developing countries at least.
Yeah, thank you so much for noting that. Just, the idea that physicians also play a major role, not just in ordering the test, but in also interpreting and making sure that the patient understands what's happening. So just moving on to something related, which we call PrEP in our world. Many of our listeners here may be familiar or unfamiliar with PrEP. PrEP is pre-exposure prophylaxis. They are also antiretroviral drugs, but they're given to uninfected individuals who are at risk of infection, and maybe due to their partners having the disease or some sort of association with people that have the disease. And PrEP typically is given to reduce chances of acquiring HIV drug, HIV itself. So my question to you, Dr. Diaz, is what should people know about PrEP, and how might these drugs, these PrEP ART drugs, contribute to HIV drug resistance?
Yes, that's very interesting. I have a reflection towards that, which is there an absolute truth in medicine? I don't know if there is absolute truth in life. Maybe death is absolute truth in life. You are born, you are going to die. But what about medicine? Well, we do not have a vaccine for prevention in HIV. And we failed a lot when we start to interfere with behavior with the patient, especially sexual behavior. Then we are forced to have something that we call biomedical tools for prevention. And then we created the drugs to prevent. For instance, you mentioned that if the viral load is below detection limit, if the viral load is zero when we use the common tests, the transmission is also zero. And that is the only absolute truth that I know in medicine. If the viral load is zero, is below detection limit, you are not going to transmit. Then we also use drugs to prevent uninfected people. You use the post-exposure prophylaxis. So you are exposed, you are going to use the same drugs for 4 weeks, something like that. And use the pre-exposure prophylaxis. So you are going to use part of the treatment, the antiretroviral treatment, not all drugs, but part of the drugs, every day to prevent HIV transmission. And this is the only thing that decreases the incidence of HIV. So this is very effective. You take the drug and you are not going to have HIV in the same fashion. But guess what? One thing that can threat the treatment as prevention, as I told you, viral loads below detection limit is not going to transmit, is resistance. Because if you have resistance, you have virus replicating. And also, when you use PrEP, the pre-exposure prophylaxis, sometimes you are going to get infected with resistant virus. We just published one case that the person was exposed to a resistance virus in the PrEP treatment that he was taking, which was Truvada, tenofovir and FTC, and he got infected. So right now, it's not honest with the patient to say that he is or she is 100% protected when he or she use PrEP, because there are those resistance parts. First, PrEP works very well if you take the drugs, and not everybody is able to take the drug with a good adherence. And second, the resistance may threat also PrEP. And it's interesting because when you talk about resistance threatening PrEP, what we see right now is something very interesting. People that are going to be infected with those drugs used for PrEP, such as Truvada or cabotegravir, which is an integrase inhibitor, second generation integrase inhibitor, they have the drug levels that are necessary to prevent HIV. And even though some of them, very few, get infected. And when you look at the virus, they carry some mutations that are related to resistance to antiretrovirals, but not specifically to that drug. They have two other classes, showing that those viruses that may have some level of resistance to any other drug or any other class may be also carrying some properties of resistance to the drug that you're using for prevention. So resistance is still something that you need to study more, to understand more, and to try at any level to mitigate in order to have a world without HIV.
Yeah, yeah. Thank you so much, Dr. Diaz. I think one of the big things that you just highlighted is, yes, PrEP is very effective. However, people on PrEP are not invincible. Like, we can't say that because you're on PrEP, 100%, you're sure that, you want that person is not at risk of getting infected. And so that's something that I think, needs to be highlighted. And so moving ahead, let's just talk a little bit about disparities. We've talked about how Brazil has done fantastic in all the strategies that they pushed forward. Well, let's talk about disparities that you've seen in Brazil or in other countries that have contributed to HIV drug resistance or impeded access to testing.
Yeah, yes. First of all, I am very proud of the Brazilian system fighting HIV because they chose a magic word for that, which is access. It's interesting because in theory, 100% of Brazilian patients, Brazilian people living with HIV have access to treatment, to monitoring tests such as viral load and CD4 counts, and to genotype. For you to have an idea, in many developing countries, the access to drugs is 50%. And in Brazil, it's 100%. And even though there are some inequities, this access is theoretical, but there are in Brazil far places where it's very hard to bring samples for genotype, for instance, or deliver drugs. We have very poor people in some parts of the country because it's a developing country, so we have that big difference between rich and poor people. And some people will not have access to food. And so the desire of giving them drugs and adherence and tests is something that is not feasible for everybody. So although we want to offer this, of course, it's not equal for everybody. And we can see this in other developing countries. I'm in contact with Latin American countries. And when you look at the drugs, antiretroviral drugs or testing, we are not able to offer this to everybody. Because even if you want to have access, the system needs another thing, that's sustainability. And so we cannot, for instance, have all the drugs that we have in US or Western Europe because they are expensive. So we have what we need, but not everything. And sometimes we have some generic drugs and things like that. And so, but we are fighting. We are fighting to keep HIV in the agenda. It's very easy to put HIV out of the agenda. Every time it's happening something. War,
Right.
epidemics, HCV. And our fight is to keep HIV in the agenda and to offer those people what they need in treatment and testing.
Thank you so much, Dr. Diaz. I think that's a message that, other parts of the world can carry forward, keeping HIV in the agenda, despite everything that's happening. So moving ahead, one of the discussions we've seen across countries is this idea of individual HIV drug resistance testing versus surveillance. So a lot of countries have in their guidelines surveillance or HIV drug resistance testing. But when it comes to using the test in individuals, countries, there's a lot of discussion around the cost effectiveness or, the usefulness in using the test for patient management. So can you just speak to why Brazil has decided to implement the test, not just at the surveillance level, but for individual patients?
Yes, well, surveillance, of course, is very important because it may shape guidelines. It may show us trends and things that we need to do, especially in resistance, because we are talking about, for instance, transmit drug resistance. This is very important. And every time that you expend some money in surveillance, you are going to save that money upfront. But also, we need to think about the cost effectiveness of using tests in an individual level. Well, when you think about people failing treatment, is the genotype test is of course cost effective, and we have many studies showing that. So when you use resistance test, we are going to, in all measures of a cost effectiveness analysis, we are going to save resource. So there is no question about that. That's why we use in Brazil resistance tests for people failing treatment. But the question is it cost effective for people that are starting treatment? I mean, in an individual level, it's very good. If this is for me, I want to do a pretreatment genotype. But if you calculate for everybody, this is not going to be cost effective. But anyway, let's think about this. When you do nucleic acid testing in blood banks for HIV, HCV, and HBV, let's talk about HIV. This is not cost effective. So for every people that you prevent an HIV transmission, you are going to pay millions of dollars for every people that has a nucleic acid test positive and a serology test negative. But it's not ethical at that point, not using nucleic acid testing in blood bank. And one could say the same about pretreatment genotype. Although it's not cost effective, at some point, maybe not ethical not using this because you have the tool. And if people has transmit drug resistance and they use the wrong drugs, they are going to increase the resistance because they are going to use more monotherapy in that treatment. So we need to think about that. Well, some people say, well, if you use a resistance test that's going to take 2 or 3 weeks to be ready, 4 weeks, you are going to save money of 4 weeks of treatment, and they may make the test a little more cost effective. Not quite, but a little bit. And the real thing is, we learned a lot, for instance, with the COVID-19 pandemic. The first thing that we learned is that the unpredictability of those things that may have in our lives is going to harm our assistance. For instance, HIV, I told you that you do 15,000 tests a month, and during the pandemic, we are doing 150, much less. And people were lost to follow up because they were told to be at home, which was right. But the other thing that you learn with the pandemic is that we can grow in science very fast. And During the pandemic, we are going to sequence virus in a very fast mode, in a very fast fashion. So we learned that we can sequence a virus that's SARS-CoV-2 that's larger than HIV very fast to monitor the trends of the variants, the strains. And you need to bring this to HIV and to increment that tool to make it less cumbersome and more fast and cheaper to have a tool to treat HIV, even in pre-treatment, using pre-treatment genotype besides genotype after upon virologic failure.
So it's possible.
Yes,
That's the message. We did it in COVID, so we can do it
sure.
for HIV. So, Dr. Diaz, so in terms of when we think about the global call to action, what groups can help us most raise awareness for increased access to drug resistance testing?
Well, what I think always is maybe our target is the education of people, those people that may be at risk of having HIV. Well, there are lots of prejudice towards HIV, but if there is some entity that has no prejudice, is the virus. The virus is going to infect everybody, and we need to know that. And so the education is something that may help a lot. Of course, you always think about authorities, government, key persons on treating people. But I think that we need to go for the base. And the base are people that may be at risk or everybody, common people that need to know that prevention is important and that need to know that adherence is important. We know that when you talk about resistance, adherence it's a huge point.
Yeah, to
Yes.
everybody. Yeah, that makes sense. So, Dr. Diaz, thank you again for your time today. As we close out, I just wanted to give you an opportunity. If you had anything else you'd like to share about Brazil's priority areas as the country addresses HIV drug resistance.
Yes, in Brazil, I used to think that we are in the best place and in the best time for people to know, to be aware of their HIV status. The best time because we have very good tools for diagnosis. So, in order to decrease the number of infected people, we need to test many, many people. That's a priority. Because if you test many people, we are going to include those people in treatment. And as I told you, you are going to make the transmission of those people to be zero. So the big goal for the world is to live in a world without HIV. And so that we need to combine interventions. One is to make diagnosis and bring those patients to treatment. The second thing is to go to zero transmission from mother to child, the maternal fetal transmission. The other thing is to increase the biomedical interventions for prevention. We need to make some research towards cure and also to fight more to have a preventive vaccine. But in every step that I mentioned to you, the big threat is resistance. So maybe the best approach that we have so far is try to mitigate resistance so that we can go ahead and move forward for an HIV-free world.
Thank you. So, with that, I'd like to thank Dr. Diaz for joining us today to discuss the work being done by the Brazilian Ministry of Health to combat the rising HIV drug resistance rates. Dr. Diaz, we really appreciate your collaboration on this episode of Science with a Twist. And one of the concluding messages is that with significant advancements that have been made in testing options and treatments available for HIV, there's still more to be done to protect the gains that we have made so far. So as we've heard today, there's still a lot more that we can do, ensuring that people living with HIV everywhere can access HIV drug resistance testing. And we have to stay vigilant with surveillance of HIV drug resistance mutations. And all these are critical steps to end AIDS and to reduce new HIV infections. I'd like to invite the audience that for more educational resources on connections between HIV drug resistance and global health equity, please visit our page, www.thermofisher.com/HIV education. Again, it's www.thermofisher.com/HIV education. And we look forward to seeing you on the next episode of Science with a Twist. Thank you.
Thanks for tuning in to this episode of Science with a Twist. This show is brought to you by Thermo Fisher Scientific, the world leader in serving science. If you enjoyed this episode, then follow Science with a Twist wherever you get your favorite podcasts.